Good morning, chairpersons, my dear friends and delegates. First of all, I would like to thank organizer Dr. Gilada for inviting me in this prestigious conference. It's really a great honor for me to be here. I'll be talking about the impact of HIV infection and cardiovascular system. So what exactly we are going to look for, this is very neglected area. Most of the time the ART medical officers are not very trained in assessing the cardiovascular disease as the HIV has become a chronic disease. So we are expecting a lot of cardiovascular comorbidities associated with the mortality in HIV. So what is the burden of cardiovascular disease in HIV population? CVD is really, in general, a leading cause of morbidity and mortality, and almost more than 17 million people lives per year, and cardiovascular disease accounts almost 30% of death in low and middle income countries. And HIV positive individuals are increased risk of cardiovascular disease with as per HIV infection and ART and other comorbid illness. So the ART antiretroviral agents are the touchstone for transforming the subacute HIV infection to chronic HIV infection. So it is requiring the treatment for many decades. And what exactly these HIV people are facing challenges that constant inflammatory damage, the immune dysfunction, and cumulative ART toxicity and comorbid illnesses, and although the impact of aging because the increased lifespan. So host, genetic, and lifestyle virus along with the ART therapy are the important risk factors for this. In HIV infected population, most of the time you see in general, these are all the multi-organ involvement. So kidney, bone, and increase the malignancy incidence, liver disease, peripheral autonomic neuropathies, including the cardiovascular disease. So in one of the studies, it's shown that relative risk of coronary artery disease, coronary heart disease, is increased by 2 times in ART population. Here is that study showing that acute myocardial infarction, acute and subacute ischemic heart disease, and atherosclerosis is the significant association among HIV populations. I think you are going to get more older people in HIV infection, and you see this age is also a important risk factor for cardiovascular disease among HIV and non-HIV in a controlled study. It has been also seen the myocardial infarction is increased by 20% relative risk among the people taking heart regimen. And the autonomic nervous system is also an important area to work on. And in a study that showed that early, the heart rate variability is one of the early detection of autonomic dysfunction of sympathetic involvement. So there are various tests to be maybe detected, the cold pressure test or Valsalva maneuver or postural hypotension and the head leg tilt test. These are all going to detect that early dysfunction of autonomic in HIV with or without ART. This is one of the studies that's showing dyslipidemia in a prospective study, observational study, showing that there is increase of the lipid profile. See, the total cholesterol and triglyceride LDL are increased at 6 and 12 months, including the VLDL, but not showing very much decrease of HDL in this study, which we are expecting. And also with the treatment, there is the weight and the BMI also increases, leading to metabolic syndrome and insulin resistance, all that. So this is a complex, really, interplay of HIV infection with the different other risk factors like smoking, dyslipidemia, hypertension, diabetic, obesity, along with other organ involvement like renal and cardiac. So what we are looking for how it is causing this. this cardiovascular involvement in HIV. It is through the metabolic dysfunction. As you know, the metabolic disease is really very commonly associated with the HIV. And the inflammatory process, immune activation, immune deficiency, microbial translocation, constant viral replication, reactivation, and persistent viral productions are the cause for the cardiovascular risk. HIV with ART and comorbidities, as it is a lifespan is increased. So dyslipidemia, insulin resistant, and body fat metabolism, the redistributions are the common outcome of this, and along with the genetic influence as found in the other disease also. So HIV infection is causing the microbial translocation in the gut, persistent immune destruction and immune suppression, and activation of the cytomegalovirus, and causing constant viral replication. So this finally leading to the chronic activation of the immune system and endothelial dysfunction, which leads to finally increased clotting tendency, and then abnormality of the lipid metabolism, and that's macrophage and T cell infiltration into the arterial wall, and then finally leading to the cardiovascular disease. So this also HIV infects the bone, different organs, thymus, liver, guts, and then it is causing the altered coagulation and also activation of the monocytic macrophage, leading to increase the incidence of atherosclerosis, vascular dysfunction, and tissue necrosis, which finally increases the increase of cardiovascular risk. Here is so HIV replication, metabolic syndrome, activation of the CMV, these other viruses, loss of regulatory cells, microbial translocation, which causes the monocyte activation, T cell activation, dyslipidemia, hypercoagulation, and finally leading to cardiovascular disease. So what are the cardiovascular disease that we are looking for in HIV population? The coronary artery disease, myocardial and pericardial disease, pulmonary hypertension, arrhythmias and sudden cardiac death, heart failure, hypertension, and other vascular disease, peripheral vascular disease are the most important outcome in HIV population. So how this coronary artery disease, that other than the traditional risk factor that known to us, age, smoking and hypertension, also the prevalence of hypertension is increased, and atherogenic also dyslipidemia in ART. The inflammatory response, procoagulant state, immune activation, vascular endothelial dysfunction are also important risk factor to increase the cardiovascular risk. So the HIV, attacking the target cell is the lymphocyte, adipocytes, and also the endothelial cells. So the lymphocytes, this causing the destruction and immune activation. The adipocytes, this causing the lipodystrophy, insulin resistance, and dyslipidemia. And then it is also causing chronic inflammation, which is also the causing microbial translocation. And finally, the most importantly, vascular endothelial cells dysfunction due to HIV as also ART, leading to the hypertension, atherosclerosis, and myocardial infarction, and increase the morbidity and mortality. This is increased lipid, increased blood pressure, increased glucose, increased body weight, obesity, metabolic syndrome, and then hypercoagulable state, and unhealthy eating, physical activity, inactivity, smoking, this leading to really a patient, HIV patient, vulnerable for development of the cardiovascular disease. And this is pericardial disease, is not very much common, but it is through the opportunistic infection if immune depressed, CD4 count is, and most of the commonest is the mycobacterium, other than this all common opportunistic infection. Pulmonary hypertension is not that common, but if it is there, we have to look for hepatitis, chronic thromboembolic state, heart failure, amphetamine use, and intrinsic pulmonary disease, the idiopathic symptoms So if it is there, the prognosis is very bad. So HIV population, pulmonary arterial hypertension, then really the outcome is very, very gloomy. Cardiac arrhythmia is one of the also important manifestation, atrial fibrillation flutter, and it is more common with the low CD4 count, less than 200, and high viral load. And it is also associated with older age, CAD, congestive heart failure, kidney disease, hypothyroidism, alcoholism. So these are the factors are also to be looked into. And this, how this is causing this? One is that the adiponectin, lipoprotein lipase suppression, and then causing the vascular endothelial through the mechanism of dyslipidemia, and thrombogenesis through the different clotting factors abnormality. And ART also, HIV, when taking ART, the insulin resistance is also increasing, the metabolic syndrome are also more highly associated with this. So increased risk in CVD along with in people living with HIV and AIDS, that as we know, the smoking, alcohol, diet, and level of exercise activity, family history of this cardiovascular risk, like the hypertension, diabetic, coronary artery disease, baseline blood pressure, waist circumference, body mass index, and the random lipid profile are also important, and blood sugar level, HbA1c, renal function. These are all have to look, I think, to assess the people, those who are living with HIV infection. Now, the most important that this has to be the chronic, the cardiovascular disease, the pathogenesis is really complex phenomena, and comorbidities are enhancing the risk of this vascular disease, cardiovascular disease, like the lifespan is increased. Therefore, we have to look for other comorbidities. HIV infection per se increases the risk of cardiovascular disease, and the primary prevention is a key in low, middle, and high economic settings. There are modifiable risk factors, so we have to assess the smoking, dyslipidemia, obesity, hypertension, illicit drug use, excess of alcohol, and sedentary lifestyles are also looked into to assess this. Myocardial disease, that infarction and ischemia are also important, and when the CD4 count is low with the ART, and arrhythmia are also very common and causing sudden cardiac death among HIV populations. So the long-term management of the patient with HIV infection has to be expanded to diagnose, treat, and prevention of the cardiovascular disease and coronary heart disease in a setting. So bringing the paradigm of cardiovascular disease prevention in HIV treatment setting is important to prevent the early detection and also management of cardiovascular risk of coronary heart disease, which is the most common and single important factor for high mortality. So monitor and treat the HIV infection, but there is no guideline or evidence to support that which ART to be suitable in a metabolic syndrome or diabetic or any other cardiovascular risk. So we need to work on that. Thank you very much for your kind attention.
Alcohol intake with ART.
Yes, alcohol is a risk factor, and interaction. You are asking interaction.
Interaction, yes, sir. Interaction with ART.
Yes, there is not very much known, but yesterday there was also interaction of alcohol and ART. There is not much of randomized trial with a high number of patients that really to say this is the alcohol has an interaction with this. I am not sure about how much it is and how much contributing the cardiovascular risk and alcohol and ART. There is no such data, authentic data to project to support this evidence. How much, what is the exact figure? I'm not sure.
You said the prognosis of people with, is it not? You said.
Pardon?
Prognosis of pulmonary hypertension, HIV is gloomy. That's what you said, I think. Yes or no?
Gloomy.
So that's what you thought.
Yeah, coronary. Yeah, with the coronary
No, no.
Heart disease.
No, pulmonary hypertension.
Pulmonary hypertension, yes, pulmonary hypertension, when it is detected, then the lifespan is very short.
But I think with the coming of ART, the prognosis is becoming better. Because in olden days, we used to see patients with pulmonary hypertension, they used to die fast. But now with ART, their lifespan is much better, much better.
Yeah, ART with the pulmonary arterial hypertension, yes, the lifespan is increased. If it is not detected, my question is that detection of pulmonary arterial hypertension, most of the time it is not looked for. So that is what, with the treatment definitely lifespan is increased.
Any other questions? If not, then we can continue with the next. Oh, sorry.
Is it necessary to check the lipid profile for all the medicines, all the ART medicines?
Yes, it is advised to go for lipid profile before ART starting, and also it is advisable to go for every 6 months for lipid profile. It should be a routine, and we are also doing in a routine. Before starting also we need to know, because HIV infection per se causes dyslipidemia.
And it should include all the 4 values.
Yeah, you have to have a 4 value, total cholesterol, LDL, HDL, and VLDL, triglycerides. So these are all to be done.
Thank you, sir.
Okay, thank you, sir.
Okay, thank you very much.
It's my pleasure to